Imagine you're in the back of an ambulance speeding over this really bumpy rural highway.
Oh yeah, worst case scenario right there.
Right. Your patient is showing these acute, escalating signs of an ischemic stroke. You know you need to deliver a life-saving thrombolytic.
Time is brain, as they say.
Exactly. But the IV infusion pump just keeps triggering these occlusion alarms every single time the suspension hits a pothole.
I mean, anyone who's worked transport knows that nightmare. You're just staring at the line.
Yeah, you're constantly checking the line, you're managing this drip, and basically just praying the drug actually reaches the patient's bloodstream before, brain tissue is permanently lost.
It's incredibly stressful.
And for decades, that tense, tethered reality, that was the standard of care when administering Alteplase.
Yeah, it was the unquestioned gold standard. Just what you did.
But suddenly the neurological guidelines are shifting, like majorly shifting.
Right.
And this really formidable alternative has entered the clinical space, which is Tenecteplase.
We are, without a doubt, witnessing a profound paradigm shift in acute neurology right now.
It's huge! Welcome to the Deep Dive Learner. Today, our mission is to give you a really comprehensive, heavily researched, and practical comparison of these two clot-busting drugs.
Because the decades-old protocols that, governed basically every ER and stroke center, they're being rewritten as we speak.
They really are. And we are pulling from a massive stack of sources for you today. We've got rapid clinical reviews, detailed methodologies of landmark trials, stuff like Original and Extend IATNK.
Plus the freshly published 2026 guidelines.
Right, the 2026 guidelines from both the AHAS and the Canadian Stroke Best Practices.
Which is a lot of data. The sheer volume of recent research can feel pretty overwhelming, honestly.
Oh, absolutely. But our goal is to funnel it all down to the specific practical reality that you, the clinician, or just the really curious learner need to navigate right now.
Exactly. Because you need to know not just what the new standard is, but why it's changing after so long.
So whether you're an ER doc staring down these updated protocols on your next shift, or you just want to grasp the mechanics of modern stroke intervention, you are in the right place. Okay, let's unpack this.
Where do we start?
Well, before we dive into the massive non-inferiority trials or the 2026 guidelines, I think we really have to look at the underlying biology.
Oh, for sure. You have to start with the pharmacology.
Because, if Alteplase has reliably dissolved clots since the 1990s, we have to ask, why did the medical community even feel compelled to re-engineer it?
It's a great question. And biologically, you have to understand that both Alteplase and Tenecteplase, they belong to the exact same class of drugs.
Right. They're both tissue plasminogen activators.
Exactly. Their fundamental mechanism of action is pretty much identical. They circulate through the bloodstream, they locate a thrombus, and they activate plasminogen into this enzyme called plasmin.
Which basically degrades the fibrin matrix holding the clot together.
Yes. It essentially chews up the net that's keeping the clot intact. But, and this is the key, Tenecteplase is a specifically bioengineered variant.
They literally tweaked it in a lab.
They did. Researchers strategically altered the amino acid sequence of the Alteplase molecule. And they did this to grant it 3 very distinct physiological advantages.
And let's break down those advantages, because those specific molecular tweaks, they basically dictate everything else we are going to discuss today.
Totally. So the first major alteration resulted in significantly higher fibrin specificity.
Okay, meaning it targets the clot much better.
Right. So instead of acting like...
It's like instead of Alteplase acting like this pharmacological carpet bombing approach, right? Where it just indiscriminately activates circulating plasminogen everywhere and depletes your clotting factors systemically.
Yeah, there's a really good analogy.
Thanks. It makes Tenecteplase function more like a heat-seeking missile. It selectively binds to the actual fibrin strands located within that specific targeted clot.
That is highly accurate. By restricting its primary enzymatic activity to the site of the occlusion, the drug theoretically reduces the systemic coagulopathy that, usually plagues thrombolytic therapy.
Which is obviously a huge win for safety.
Huge. Now, the second structural modification grants Tenecteplase this profound resistance to something called plasminogen activator inhibitor 1.
Right, commonly known as PAI1.
Exactly, PAI1.
And just as a refresher, PAI1 is the body's endogenous regulatory mechanism, right? Like when a clot begins to break down, the body naturally releases PAI1 to basically pump the brakes on the whole thrombolytic process.
Yes, trying to prevent excessive bleeding. It's a survival mechanism. PI1 rapidly binds to and deactivates wild-type tissue plasminogen activators like Alteplase.
It just shuts them down.
Exactly. But because of its modified amino acid sequence, Tenecteplase essentially evades PII-1.
Wow, so it just ignores the brake pedal.
It completely ignores the physiological brake pedal. This allows the drug to persist and exert this sustained thrombolytic effect directly at the occlusion site.
That is wild.
And that natural persistence leads right into the third, and honestly perhaps the most clinically disruptive advantage, which is a substantially longer half-life in the bloodstream.
Okay, yeah. And that extended half-life completely alters the mechanics of how we actually administer the drug.
Oh, fundamentally.
Because if we look at the logistics, administering Alteplase is a bit like setting up a complicated pour-over coffee.
Or over coffee. I love that.
Right, because it requires time, specific hardware, continuous monitoring. I mean, you push an initial 1-minute bolus containing just 10% of the dose.
Right, just 10%.
And then you have to hook the patient up to an IV infusion pump to continuously deliver the remaining 90% over a full hour.
Which is incredibly cumbersome. Tying a critically ill, hemodynamically fragile patient to an infusion pump, it really limits their mobility and complicates basically every subsequent step of their care.
Exactly. But because of that extended half-life and that PAI-1 resistance we just talked about, Tenecteplase is delivered like a single shot of espresso.
A single shot, exactly.
You completely bypass the hour-long drip. The entire dose is just administered as a single IV bolus pushed over 5 to 10 seconds, and boom, the administration is entirely complete.
Which is, the implications of that single bolus delivery cannot be overstated.
Yeah.
Particularly when we analyze the drip and ship workflow model.
Right. And for those listening, the drip and ship is the standard operating procedure when a patient presents to, say, a smaller rural hospital or a primary stroke center.
Right, a place that can't do neurosurgery.
Yeah. So they receive the thrombolytic locally, but then they require immediate interfacility transport, usually by ambulance or helicopter, to a comprehensive stroke center for mechanical endovascular thrombectomy, or EVT.
Yes, and in a traditional Alteplase protocol, the transport team must continuously manage that active infusion while they're, physically moving the patient onto a stretcher, navigating hospital corridors, bouncing around in the back of an ambulance.
It's a logistical nightmare.
It really is. If that IV line kinks or infiltrates or, say, the pump battery just fails during transport, the patient's critical therapy is instantly interrupted.
But with Tenecteplase, the physician just pushes the bolus in the ER, the line gets flushed, and the patient is placed in the ambulance entirely untethered.
Entirely untethered. There is no infusion to manage whatsoever.
Which dramatically simplifies the cognitive load on the transport team, right? And it completely eliminates the risk of an interrupted dose.
It does. It's a massive relief for paramedics and transport nurses.
Okay, so the workflow improvements are undeniable. I mean, you eliminate the delay between the bolus and the infusion, you strip away the math of programming a pump during a high-stress code stroke, but yeah. As you know, logistical convenience alone doesn't justify overhauling a global neurological protocol.
No, absolutely not. You can't just switch a major life-saving protocol to save the nurses some hassle. The transition has to be anchored in rigorous clinical equivalence.
Which is exactly what drove the recent wave of these large-scale Phase 3 non-inferiority trials in the sources.
Right. Over the past few years, the international stroke research community sought to definitively prove that replacing that hour-long infusion with a 5-second bolus would not compromise overall functional outcomes across, broad general stroke populations.
And the sources outline a very clear global scorecard here. The acute trial in Canada randomized 1,600 patients back in 2022, and that established early non-inferiority.
And then the data pool expanded significantly. We saw the TRACE-2 trial out of China in 2023, and then the ATEST-2 trial in the UK in 2024.
And they all coalesced around the exact same conclusion regarding functional independence at 90 days, which is typically measured by a modified Rankin scale or MRS of 0 to 1.
They did, but the sources particularly highlight the original trial, which was published in 2024.
Yeah, let's talk about the original trial because it serves as this really robust contemporary benchmark. They analyzed 1,489 patients across multiple centers. And the functional outcome data showed Tenecteplase achieving excellent outcomes in 72.7% of patients compared to 70.3% for Alteplase. So it easily cleared the statistical threshold for non-inferiority.
It really did. And critically, it demonstrated comparable safety.
Which is always the biggest fear, right?
Oh, exactly. The primary fear with any thrombolytic switch is a potential increase in symptomatic intracranial hemorrhage, or SICH.
A brain bleed.
Right. But in the original trial, the rate of SICH was completely identical between both cohorts. It was anchored at a very low 1.2%.
Wow. Identical.
What's fascinating here is just how consistently these independent global trials operating across entirely different healthcare systems, varying patient demographics, they all replicate that exact finding.
That Tenecteplase provides equivalent functional outcomes and equivalent safety for the all-comers stroke population.
Exactly. Just as good, just as safe.
But, reading through the methodology of the original trial in our sources, there's a really significant variable regarding the trial design that stands out. And I want to ask you about it.
Oh, sure. What is it?
It brings up this concept of spectrum bias. So let's look closely at the patient population they selected. Nearly 40% of the patients enrolled in the original trial presented with mild baseline stroke severity.
Ah, right. Specifically an NIHSS score of under 6.
Exactly. So my question is, if you are flooding a clinical trial with patients who are statistically highly likely to recover well anyway, just through natural collateral circulation or spontaneous recanalization, doesn't that spontaneous recovery act as kind of a smokescreen?
It absolutely does.
Because it makes it artificially easy to prove that a new drug is statistically non-inferior, right? Because the natural healing process is sort of diluting the measurable impact of the drug intervention.
You've hit on a fundamental limitation of broad non-inferiority stroke trials right there. When a substantial portion of your cohort has mild deficits, the high baseline probability of them just naturally achieving an MRS of 0 or 1, it drowns out any subtle differences in the true enzymatic efficacy of the drugs.
And the subjective nature of assessing functional independence 3 months post-stroke probably further blurs the data, right?
Oh, totally.
It's like if you test 2 different stain removers on a shirt that isn't really heavily soiled to begin with, they both appear to perform flawlessly.
That's a really sharp way to look at it. And it's exactly why we cannot rely solely on the broad averages of an all-comers population to understand the true pharmacological power of this drug.
Okay, so where do we look?
To see where the biological advantages of Tenecteplase, the higher fibrin specificity, the evasion of PI1, where those actually translate into measurable clinical superiority, we have to clear that smokescreen.
Right. We have to look at the sickest patients.
Exactly. We have to look at the most severe subgroups.
Here's where it gets really interesting, because we're stepping away from the mild deficits and looking directly at large vessel occlusions, or LVOs.
Yes, the catastrophic strokes.
Right, where a massive, dense thrombus is just completely blocking a major cerebral artery, like the M1 segment of the middle cerebral artery.
And these are the exact patients who are rapidly fast-tracked for endovascular thrombectomy.
EVT.
Right. They desperately require a neurointerventionalist to thread a catheter into the brain and physically extract a clot. And this specific high-stakes scenario was the focus of the landmark Extend EATNK trial back in 2018.
So in Extend EATNK, they administered the thrombolytic to LVO patients prior to taking them into the angiography suite.
Right.
And what's cool is the primary endpoint wasn't just a subjective functional interview 90 days later. It was hard angiographic evidence.
Yes, actual imaging.
They wanted to know if the IV drug could dissolve more than 50% of the occlusion before the surgical team even deployed the stent retriever.
And the data from that angiographic endpoint is striking. I mean, it's really clear. For patients receiving Tenecteplase, the rate of substantial early reperfusion prior to EVT was 22%.
Wow.
But for those receiving Alteplase, it was only 10%.
So the single bolus effectively doubled the likelihood of clearing the vessel on its own.
Doubled it, yes.
That is a highly significant biological edge. It makes sense, though. When the clot burden is really high, that heat-seeking missile mechanism finally has the dense fibrin matrix it needs to demonstrate its superior binding affinity.
That's exactly the mechanism at play. And we see that same biological edge manifesting in highly specialized pre-hospital environments, too. The sources extensively detail the TASA trial, which is really cool.
Oh, yeah. The one conducted entirely within mobile stroke units.
Yes, which represents the absolute frontier of acute care.
For you listening, these are specialized ambulances equipped with onboard CT scanners and a dedicated neurology team. They allow for diagnosis and drug administration literally in a patient's driveway.
It's incredible technology. In the TASTA trial, patients diagnosed with an ischemic stroke inside the mobile stroke unit were randomized to receive either Tenecteplase or Alteplase immediately.
Right in the rig.
Right there. And then the researchers measured the volume of the perfusion lesion, which is the specific area of ischemic brain tissue, the moment the patient arrived at the emergency department.
And the results there were equally compelling. The median perfusion lesion volume for patients who received Tenecteplase in the field was just 12 milliliters upon hospital arrival.
But for the Alteplase cohort,
The median volume was 35 milliliters.
that is nearly a threefold difference in the volume of brain tissue actively undergoing infarction during transport.
Wow.
It visually, tangibly quantifies the speed and the efficacy of that Tenecteplase bolus.
Okay, but if Tenecteplase is definitively more powerful at attacking large, dense clots, human nature sort of dictates a dangerous logical leap.
Oh, I know where you're going with this.
Right. The instinct is to assume that, hey, if the standard dose produces exceptional reperfusion, well, a higher dose might just guarantee it. Like if you have a really stubborn, large vessel occlusion, why not push more drug?
Because in neuropharmacology, crossing the dosage threshold rarely yields proportional benefits. In fact, it frequently triggers catastrophic toxicity.
And this brings us directly to the severe safety warnings documented in the literature.
We have to talk about Nortest 2A.
Yes, the sources explicitly highlight the Nortest 2A trial, which really serves as the stark clinical warning against any kind of dose escalation.
Nortest 2A was a phase 3 trial, specifically designed to test that exact hypothesis you just mentioned.
Right.
The investigators wanted to determine if administering a higher dose of Tenecteplase, specifically zero point 0.4 milligrams per kilogram, would yield superior functional outcomes for patients with moderate to severe strokes.
Compared to standard Alteplase.
Exactly.
And the Safety Monitoring Board had to abruptly halt the trial prematurely, right?
Slam the brakes. It was halted because the zero point 0.4 dose proved to be deeply, deeply unsafe.
What happened?
The higher concentration of Tenecteplase resulted in worse overall functional outcomes, increased mortality at 3 months, and a drastic escalation in bleeding complications.
It's terrifying.
Intracranial hemorrhages of any classification occurred in 21% of the patients receiving the high-dose Tenecteplase,
21%. Compared to what in the control?
compared to just 7% in the Alteplase control group.
It is so crucial to understand the mechanism behind that failure. Because when you push the dose to 0.4 millikilograms, you basically overwhelm the drug's relative fibrin specificity.
Yes.
The plasma concentration just becomes so high that the drug saturates the available clot and then begins aggressively activating circulating plasminogen throughout the entire system anyway.
Right. Spills over.
Effectively recreating the systemic coagulopathy that Tenecteplase was literally engineered to avoid, but at a much more aggressive rate.
Exactly. The physiological specificity is heavily dosage dependent, which is why the current medical consensus is completely unyielding on the acceptable parameters.
We need to state this explicitly for you listening just to ensure absolute clarity on the clinical guidelines.
Please do.
The only proven safe and approved dose of Tenecteplase for acute ischemic stroke is 0.25 milligrams per kilogram, and that is capped at a hard maximum of 25 milligrams total.
I'll repeat it just to be sure. The 0.4 millikilogram dose has been definitively abandoned in stroke protocols. Adherence to the 0.25 standard is non-negotiable.
But, the danger of overdose doesn't just stem from theoretical trial designs. It actually stems from a very real logistical hazard currently sitting inside hospital pharmacy dispensing cabinets across the world.
Oh, this is such an important point.
Because Tenecteplase was not initially developed or marketed for acute ischemic stroke, for years its primary application has been the treatment of acute myocardial infarctions, STEMIS.
Heart attacks.
Right, and the established cardiac dose for a heart attack is 0.5 milligrams per kilogram.
Which is precisely double the maximum approved neurological dose.
Exactly. And the sources warn that many hospital pharmacies still stock Tenecteplase in packaging and concentrations designed around that cardiac indication.
Yes.
So in the chaotic, high-stakes environment of a code stroke, if a clinician reaches for Tenecteplase and inadvertently applies the ingrained cardiac dosing protocol, they will administer 0.5.
And administering double the stroke dose would almost certainly induce a massive, fatal intracranial hemorrhage. I mean, this represents the single highest risk hurdle of the entire transition period.
It's a huge operational risk.
Hospitals cannot simply substitute the vials in the automated dispensing cabinets and expect a seamless transition. It requires rigorous, system-wide education.
Explicitly redesigned stroke-specific order sets.
Yes, and strict barcode verification protocols to ensure the cardiac and neurological doses are never, ever conflated.
So, okay. Synthesizing all of this, the expansive pharmacology, the non-inferiority data from the original trial, the LVO superiority we saw in Extend IUTNK, and these really rigid safety parameters. how does this aggregate into the current reality of clinical practice?
The landscape has definitively solidified. Following FDA approval for the stroke indication in 2025, the major governing bodies have fully aligned their directives.
Right. The 2026 guidelines from the AHASA, acting in concert with the updated Canadian stroke best practices, have formalized the transition.
And they aren't framing Tenecteplase merely as an acceptable substitute anymore.
No, the language is far more assertive than that. The 2026 guidelines explicitly endorse Tenecteplase at the 0.25 mg/kg dose as the preferred first-line thrombolytic agent over Alteplase for eligible patients presenting within the standard 4.5-hour symptom onset window.
It's the new standard.
So what does this all mean for you in your clinical practice? Let's distill the core operational takeaways.
Number one.
First, for the general all-comers stroke population presenting with mild to moderate deficits, you can expect functional outcomes and safety profiles that are completely equivalent to Alteplase, provided you strictly maintain that 0.25 dosage gap.
Absolutely.
Second, when treating severe large vessel occlusions, Tenecteplase provides a biologically superior mechanism for early reperfusion prior to mechanical thrombectomy.
Heat-seeking missile effect.
Right. And third, the shift from an hour-long pump infusion to a single 5-second bolus fundamentally optimizes emergency department workflow, and it significantly de-risks the drip-and-ship transport model.
It is incredibly rare in modern pharmacology to adopt an intervention that simultaneously demonstrates superior efficacy in severe pathology, broad non-inferiority in general pathology, and vastly simplified administration mechanics.
It's kind of the holy grail.
It is. That unique triad is exactly why the neurological community has moved so swiftly to rewrite the standard of care.
It represents a really elegant refinement of acute intervention. But as we know, the boundaries of neurological intervention are never static. They're always pushing.
If we connect this to the bigger picture, this transition raises an important question about what happens next.
Yeah.
Well, everything we have analyzed today operates strictly within the traditional 4.5-hour temporal window from symptom onset.
Right.
But the biological durability of Tenecteplase is prompting researchers to test those limits. Emerging data from trials like TRACE-3 and OPTION are actively investigating the administration of Tenecteplase in the expansive 4.5 to 24-hour window,
Wow, up to 24 hours.
utilizing advanced perfusion imaging to identify salvageable penumbra. Yeah.
I mean, expanding the administration window out to 24 hours would completely redefine the accessibility of acute stroke care.
Imagine the clinical implications for a patient residing in a remote region who experiences a wake-up stroke, where the exact time of onset is unknown, and they are entirely isolated from a comprehensive stroke center capable of performing EVT.
Which is a tragic but very common reality.
Right. If advanced imaging confirms salvageable tissue, a single bolus of Tenecteplase administered 12 or maybe 16 hours after onset could become their sole biological lifeline to functional independence.
That is amazing.
That is the horizon the scientific community is moving toward right now.
That potential for expanding access is an incredible concept to end on. The foundational protocols have officially changed, and the tools are just becoming more and more refined. Thank you for joining us on this deep dive. If you operate within an emergency or neurological setting, take this analysis as the catalyst to review your institution's updated order sets.
Verify your dispensing safeguards to prevent that cardiac dose confusion.
And ensure your clinical team is fully prepared to execute the new standard of care. Keep analyzing the data, keep challenging the established norms, and we will see you on the next deep dive.